So if yes, if we say yes, this Paget disease, expansion, the target of the Paget is the iliac bone. Okay, you will find expansion, coarsening of the trabeculation. You cannot differentiate between the cortex and the trabeculation. You have in the musculoskeletal, in the X-ray, you have to have the reference in your mind. The reference could be the medulla and the cortex, the other side. Okay, you understand that you have to have your reference. You cannot say this osteoporosis. Why osteoporosis? Because it appear apparently lucent. Why lucent? Why lucent to which? That when you say lucent, that osteoporosis mean that thinning of the cortex like that. You have to have your reference. You have to say some measurements, not just to spit it out. I'm sorry for the word. Spit it out. This is lucent. This is osteoporosis. This is not something, not scientific terms. You can be true sometimes, but this is not scientific term. And don't call it. It is the eye experience, because this was with the factors when we were using the factors in the X-ray. But now everything is digitalized. You can be deceived easily. Can be easily deceived by some playing in the factors in the workstation. Okay, so it is expansion. When I compare expansion or not expansion, sclerosis or not, it is sclerosis. Can you say that this cortex, this medulla like this cortex? Yeah, so sclerosis, benign or malignant, is apparently benign. So at that age, at that site, and this involvement, you see this thickened, very thickened compared to this. So what is this? Paget disease. MRI, no MRI, unless there is malignant transformation. Okay. Next is Langerhans cell histiocytosis. When you say this, it is almost systematic disease. Okay, you have to search for the skull. Okay, the lytic lesion in the skull. What is the name of the lytic lesion in the skull? In the chat. Button sequester. Yeah, great. Okay, in the mandible. Okay, in the vertebra plana, and in the chest, involvement of the chest. Okay, thank you, floating teeth. Thank you so much. Okay, this thinning of the alveolar margins. Okay, and the resorption. What is the other disease which affect the alveolar margin and the what else? No, and hyperparathyroidism. This, yeah, very good. Yeah, very good. Okay. Next is the myths. Most common tumor: breast, prostate, kidney, and lung. MRI is very sensitive in detection of lytic lesion. Okay. Bone scan more sensitive in osteoblastic lesion. Bone scan is not helpful in diagnosis. Don't forget that. Don't tell the examiner for multiple myeloma, bone scan. No, don't do that. Bone scan is not good for assessing the multiple myeloma. Okay. Multiple myeloma is the most common primary tumor in adult soft tissue masses. Structure can present with in the literature, which is not so practical. When it is one single lesion, it is plasmacytoma. But I attend the myeloma MDT, and I can say that the hematology team call any soft tissue involvement as plasmacytoma. Okay, if not the bone, it is plasmacytoma. Okay, and the literature say only single lesion to call plasmacytoma. But I can say the hematology team say that when there is non-bony involvement, it is plasmacytoma. Okay, and the MRI is low, high, and homogeneous enhancement in post contrast when it is active. is a multiple myeloma, and this is low signal T1 and this is high signal T2. You can, in the multiple myeloma, don't forget, you ask for skeletal survey. Most of the time now, for the axial, for the spine, they ask for axial, for MRI, for the spine and the pelvic bone, and for the peripheral skeleton, we ask for X-ray. This is myths from the prostate. What is the other tumors which can be a reason for sclerotic myths? Yeah. Anything in the chat? Okay, great. Thank you so much. In the FRCR, breast cancer is considered as one of the reasons for sclerotic myths, not lytic myths. Okay, although the breast can send the sclerotic or lytic myths. Okay. Okay. These are myths. Lytic myths, destructive myths, the renal myths, the huge destructive lytic lesions. Okay. Back to the diagram. So we finished the proximal thigh, the metastatic. So the proximal thigh now. Bone cyst, there is no fluid level, pathological fractures, and the fallen fragment sign. Okay. Fluid level, it is aneurysmal bone cyst. Osteoid osteoma, the nidus, in the bone scan, it is donut sign. Okay. It is very, when you find this area in the exam, it is osteoid osteoma or stress fractures. Okay. Nothing else. Okay. Nothing else. Here it is, the multiple hereditary exostosis. When we say that there will delivery, there is the length discrepancy in the length of both lower limbs, as because the bone is consumption of the bone to develop in this region. Instead of mineralization into this area, all of these go to this region. So this is expected to have some shortness at that limb and some shortness in that limb because the bone is consumption of the bone. Okay, so this with multiple hereditary exostosis was called before diaphyseal achalasia, was misnomer, but the multiple osteochondroma is high propensity for malignant transformation, malignant degeneration. Okay, so this is multiple hereditary exostosis, and you have to do bone scan because there is a high possibility for malignant transformation. Okay, and you will find it around the ankle, around around. If you do X-ray for the knee, you will find it. Once you find it, you will find it. Okay. Osteoblastoma, it is osteoblastoma, but large size, more than 2 centimeters, 2.5 centimeters. Okay, and it is not painful like the osteoma. It doesn't respond to acetylsalicylic acid. This chondroblastoma, subensile chondrogenic lesion, it is more in the epiphysis or the epiphyseal equivalent. Okay, here there is mets. It can send the mets to the lung. Yeah, but it can send. But also this doesn't say that it's malignant. But because some giant cell tumor can do that, send the mets to the lung. Even endometriosis can send some things to the lung. It's a catamenial pneumothorax, I think. Yeah. So we have lytic lesions here. This is malignant fibrocystoma and the fibrosarcoma, large lytic lesions, expansile, cortical breaking through. It will be in the MRI, enhancing in the MRI, and this is the internal calcification. This is chondrosarcoma, not, I'm sorry, this is internal calcification, lucency, endosteal scalloping, more than 2/3 of the diameter of the cortex and the internal calcification, the age, so this chondrosarcoma. Okay. Next is innominate bone involvement in innominate bone, lymphoma, osteosarcoma, Ewing sarcoma. Okay. This lymphoma sometimes expansile, sometimes sclerosis, mixed sclerosis and lytic lesion involvement soft tissue. I told you something a few moments ago and another thing now. So nobody can say unless ruling out the other factors. Okay, because you here, one of the cases in my experience, there was a lesion like that, and I called it Paget, but associated with soft tissue component and was biopsy and was lymphoma. Okay, so lymphoma should be reserved in your mind all the time, but there is no calcifications. Sclerosis with no calcifications. Okay, here it is, large soft tissue component, not large soft tissue component, but the mainly bone destruction and demineralization. I'm sorry, mainly ossification, expansile, destructive lesion. You cannot call it iliac bone if you don't know that. If I hide this region, if I hide this and give you this region, you cannot say that it's iliac bone. Disfigurement, destruction, ossifications, and some periosteal reaction. It is not so obvious because the destruction everywhere, and soft tissue and the set of soft tissue components, and all of this, you see all these black is calcifications. So it is osteosarcoma. Okay. Ewing sarcoma, soft tissue compared to the bone. Eosinophilic because it is permeative. It starts in the bone, but it goes through the pores, penetrate through the bones and through the pores into the bone, make small pores in the bones, and then go into the soft tissue. So the soft tissue is huge involvement compared to the bone itself. Okay. You see that? So for that reason, you can find that that's the degree of destruction of the bone, not like the osteosarcoma. No destructive bone tumor like osteosarcoma. Okay, that's it. Sacrum, chordoma until proved otherwise. Then I have to search for the atlantoaxial articulation. Chondrosarcoma. So here it is. This chondrosarcoma or chordoma, osteomyelitis, Metz, or giant cell tumor. I'm a cheater. Don't trust me. Chondrosarcoma. But this is not chondrosarcoma. Yeah? Here it is chondrosarcoma. This chordoma. And this is the. I will show you the answer. When you find this is not when you find a lesion like that, this is chordoma until proved otherwise. But in this case, if we speak about this case, this is not the same tumor, the same lesion which I show you below above. This most likely this chondrosarcoma, this chordoma, but here there is sacral chondrosarcoma artificially eccentrically in the upper portion of the sacrum, off midline. This lesion is a midline lesion. So this is chordoma, not chondrosarcoma. But here's just I want to show you the difference between these things. Here it is. This chondrosarcoma, this chondrosarcoma, and this chondroid matrix, the rings and the arcs, and the high signal in the fluid sensitive sequences, the low in T1 signal, and the heterogeneous enhancement. Okay. Here is a chordoma midline involve the sacrum, don't forget to have a look on the atlantoaxial articulation. Okay, the clivus. I'm sorry, the clivus. Okay, this is the most common primary malignant tumor of the sacrum. Most commonly in the sacrum, this large lytic lesion. Okay. Here's the chordoma, other examples for the chordoma, low in T1 and the high signal in T2 signal, and the enhanced avidly in post-contrast sequences. Okay. Here is the giant cell tumor. This is the most common benign sacral tumor. Benign sacral tumor. It is eccentric in the upper sacrum, like the chondrosarcoma. It doesn't show calcifications. Okay. It may abut and extend through the sacroiliac joint and disc space, and can, as giant cell tumor, this can coexist with aneurysmal bone cyst. Okay. Here's other example for giant cell tumor. It is not midline. It is mainly in the. It is mainly paramid. Just not mainly in the midline. It is paramedian. Okay. So what is this? There is pathological fractures inside the giant cell tumor. Okay. So giant cell tumor doesn't show internal calcifications. Pathological fracture can happen in any single tumor. If it is involving the paramedian, the bone, the upper sacrum, and with no calcification, we differentiate it from chondrosarcoma. Okay. The myths, the direct myths, colorectal and prostate, and the indirect myths, colorectal, breast, thyroid, renal, melanoma, and prostate. Okay. Here is the example for the myths. This is the next case. What do you think? Avulsion of the lesser trochanter. What is the next step? Chest, CT chest, abdomen, pelvis, open reduction, CT guided biopsy, reassurance. Okay, great. Here is renal cell tumor. Okay. And this treatment. Okay. Pathological avulsion fracture of the lesser trochanter. When you find lesser trochanter in old age, lesser trochanter avulsion, it is malignant until proved otherwise, either myeloma or metastatic. Okay. It's just, I'm sorry, I will try to wrap the rest of the tumors. Here is the lesion in the when just what is had been highlighted, and we're using the lens. Benign avulsion when young patient and athletes, young patient or adolescent, developing apophysis because the apophysis, the site of insertion of the tendons, is weaker compared to the tendon itself. So it can easily to be avulsed. The weakest point at any tension is the site of insertion. So this can be avulsed, the weakest point. But in older age, when it becomes weak, if there is metastatic deposit, malignant transformation, so it can be avulsed. Okay. His anterior superior, here the site anterior superior spine, sartorius, anterior inferior spine, rectus femoris, scale, teoprosty, hamstrings, lesser trochanter, iliopsoas. Okay. It is this example when it is young, it is iliopsoas, but when it is old, should be malignant until proved otherwise. Okay. Here it is another benign avulsion fracture. It is malignant, and here it is primary. Okay. Next case, what do you think? This infection, Langerhans cell histiocytosis, osteoid, osteoma, stress fracture. Okay, great. Osteoid osteoma marked smooth cortical thickening, medullary sclerosis, nidus is seen at the corticomedullary junction, and internal mineralization, bone scan, donut sign. This is the nidus. Okay. bone scan, donut sign, okay, or double dense sign, okay. Next differential is the osteomyelitis. We have the Brutus abscess, cortical thickening, Leucent lesion, don't have intense radionuclide centrally in the bone scan. Not like the nidus. It is reverse compared to the nidus. Intraosseous, because dead bone, this dead bone, how it will not take anything, okay? Intraosseous abscess should show no uptake, okay? These examples, and this the sinus tract to the soft tissue, and it is filled with granulation tissue or secrete or discharge. Thus, granulation tissue when it healed, and when during the activity it is filled with pus. So the history and the labs is very important. Okay, fever like that, pain, short duration of pain like that. Langerhans histocytosis, reactive or neoplastic, could be single, more than multiple, and usually children you see this smooth periosseal reaction, and I have you check the other region, the skull, the mandible, and the chest. Okay, but apparently in the MRI, you can see in the MRI very aggressive. So you have to return back to the X-ray and the other side and the history of the patient. Okay, what do you think? What do you think? This is osteochondritis dissecans, but here this is not osteochondritis dissecans. This is normal developmental due to the apophysis. Okay, so total jump, and the second claim that this osteochondritis dissecans. Okay. Other example in the foot. This just collection for the pathology in the foot, osteochondral defect, geode, chondroblastoma, the equivalent, this Stida process, geode, okay, and this geode. And here aneurysmal bone cyst, here is chondroblastoma, this chondromyxoid fibroma, large lytic lesion, hypervascular lesion, okay. Ewings, but this is not so obvious. This is a bit odd. I do need MRI to call it Ewings. And this is glomus tumor. Glomus tumor involve the nails, the distal phalanx, very vascular tumor, low T1, very high in T2, and the intense enhancement. And the history is very important. The history is very important. It's very painful. Glomus is very painful. Okay. But it is in the spine. If we jump into the spine, we can divide this, the anterior arch and the posterior arch. Anterior arch more common to be associated with benign tumors, and malignant more common to the body more common to be associated with malignant tumors. But whatever, malignant for the anterior arch, plasmacytoma, lymphoma, chordoma. For the benign hemangioma, intraosseous hemangioma, eosinophilic granuloma, and giant cell tumor. For the benign, for the posterior arch, aneurysmal bone cyst, osteodyostoma, osteoblastoma, osteochondroma, the malignant osteochondrosarcoma, and the osteosarcoma, and the Ewing sarcoma. Examples according, and the classification according to the age, you have to classify them below according 30 years old. The most common malignancy in the young age is Ewing and osteosarcoma, and the most common in the when it is young patients, aneurysmal bone cyst, as we mentioned above, chondroblastoma, and all of these tumors. Okay, here it is. This is the lesion. What do you think about this lesion? This osteoid osteoma, don't be dumbfounded, just to be treated with the matrix lytic lesion, surroundosclerosis in the spine. This is more common to happen in the posterior element, but it is now in the anterior element with these features and the patient's history, the pain, and the enhancement. There is enhancement. Okay. Here it is, Volka's sign, hemangioma, striation, And in the MRI, it is low in the T1, and the high could be high in T1 if there is fat signal and fat rich hemangioma, high in T1 and lower in the fat suppression sequences. But if atypical, it can present the high signal. And to differentiate the pathological neoplastic lesions from hemangioma, you have to do what's called in and out of phase. If it lost the signal out of phase, this means that the patient is more likely to have hemangioma. Okay. Here is the next. Sorry. We have lytic lesion. What do you think? This lytic lesion in the spine. It is in the C1. This is more likely to be, could be, if the recent history of infection. I will still call it osteomyelitis, but with this pattern, with this appearance and the lack of the history of infection, I will call it eosinophilic granuloma, especially in young age. This heterogeneous hyperintensity to and homogeneous enhancement post contrast. Okay. Here it is. The next is aneurysmal bone cyst. Don't forget the fluid signal. Okay, there is expansion. There is fluid signal more than 70% of the tumor. Okay, don't forget aneurysmal bone cyst can show some enhancement of the internal septation. Okay. This is the next giant cell tumor. There is no calcifications. The signal is low signal. Okay, and mainly involve the posterior element, but extend also to the posterior anterior element. Okay, this osteoblastoma, it is like osteoma, but it is larger size, involve mainly the posterior element. Okay, it's osteochondroma. You can see this. It is very obvious in the CT. And you can find this other form of the osteochondroma. Multiple fluid level. So what do you think? Is aneurysmal bone cyst. Okay. So there's another diagram. That is the same diagram which we explained. This don't forget the bone island, sclerotic, brush borders. When the borders exceed the 1060, this is more likely to be bone cyst rather than sclerotic mets. Okay. Giant cell tumor of the sacrum, eccentric upper sacrum, not like the cordon. Okay. Bolka's dot sign hemangioma. Bolka's dot sign hemangioma. Here it is the chondrosarcoma. When you find this, I'm searching for some calcifications like that, some calcifications, but still I cannot say that until I gather all the findings. There's some calcifications here. It is destructive lesions. Actually, I cannot say the chondrosarcoma unless referring the patient for biopsy. This is pathologically proved. Okay. Here it is that when you find this vertebra plana, so the destruction of the vertebrae, single destructive lesion, plasma. If in old age, I will call it plasmacytoma. If multiple, it is multiple myeloma. You see, it is the how to differentiate between the plasmacytoma and the other tumor like that with features like hemangioma. He said many brain appearance in the CT and the MRI. Actually, it is not so widely established concept, but it can help. This is a lymphoma, heterogeneous low signal, heterogeneous enhancement, heterogeneous signal in the fluid sensitive sequences, sclerosis and lytic lesion, mixed sclerotic and lytic lesion, and the large soft tissue component lymphoma should be in the differential. Okay. The notochords, chordoma, clivus, and the sacrum. So it is the most common site for the chordoma. Don't forget the midline, not juxta, midline. Okay. Other tumor lesions. Here it is the osteosarcoma. The most important finding is the mineralization. This is the metabolic bone disease, Paget disease. You find the picture frame. This large sclerosis, low signal in the T1, loss of signal. So this picture frame. In the hands, you'll find this continuous with the medulla. This osteochondroma, is osteoid osteoma. You see this, and here the chondroblastoma, and sometimes this you have to make sure that's chondroid matrix, chondroblastoma in the epiphysis, and also can be ganglion cyst. Okay, this is very common also, ganglion cyst, and the glomus tumor, distal phalanx, very highly vascular tumor, lytic lesion, low T1, high T2, intense enhancement in the post-contrast study. Aneurysmal bone cyst expansion, and the multilocular lesion, and in the MRI you will find, I hope, this giant cell tumor. No MRI for the aneurysmal bone cyst. This giant cell tumor involving mainly the epiphysis and with closure of the epiphyseal plate. Okay, this fibrous dysplasia expansion, mixed, mainly lytic, ground glass, not ground glass. This ground glass, not leucency. Leucency. This is not chondroid, and this is the sclerosis with time. Okay. This intraosseous epidermal inclusion cyst following the needle, or like that, needling into the bone. So it is called intraosseous epidermal inclusion cyst. You know that when during using the needle like that, and then when it penetrates the skin, it can be the reason for this lesion. Okay, there are these neural lesion, bizarre, barostial, osteochondromatous proliferation. You can find these lesions, these structures. I think I show you these structures in the first lecture, and I hope you remember it. Still remember it. These bizarre. There is no medullary continuity with the mother bone, which is the main differentiating point between it and exostosis. Here is periosteal chondroma. You see, periosteal chondroma, it is just mineralization, high signal chondroid matrix, and it seems that there is some bony outgrowth which connect this lesion to the mother bone, but it is periosteal chondroma. Okay, the signal, some continuity with the bone, juxtacortical, mainly bony outgrowth from the mother bone, and the high signal of the chondroid matrix. Okay, this intraosseous hemangioma, you can see the striation and the large soft tissue component, and the MRI you will find it. You can find associated soft tissue components. It is not. But for me, it is the diagnosis of the exclusion. Okay, you have to exclude other things, and when you find this striation, this means that this is hemangioma. Okay, this Paget disease, you thicken the cortex and the medullary coarsening, which I do believe that it doesn't. I cannot say other differential except Paget disease. The cortex are very obvious to be thickened, medullary coarsening. So this is Paget disease. Just what to do? Search for the other side, the iliac bone and the iliopectineal line. Okay. Here is intraenchondroma. This intramedullary hyperintense signal expansile. Don't forget the pathological fracture in the lapid. If you don't mention it, you will miss the half of the mark. Okay. Ollier disease, multiple enchondroma, and here it is chondrosarcoma. It is malignant transformation. The first sign is the endosteal scalloping, and if the patient developed newly, there is history of newly developed pain. Okay, Ewing sarcoma in flat bones, especially with older age, or in the small bones, especially with the older age. Okay, you can find here that the epiphysis is closed. Osteosarcoma, there is intensive calcifications. Osteomyelitis, still you have to review the patient history, and this is hyperparathyroidism, where there is erosion of the radial aspect of the middle phalanx of the second and third and fourth fingers. Okay, here it is just angular exostosis, and here is the diagram for the multiple lytic lesion. Actually, I got this from the literature. This is not my effort, and they just in the first way. That these chest wall tumors, according to children, young adults, and the adults, and it is bone tumors for the chest wall. Here it is Ewing sarcoma, the soft tissue involvement compared to the bone involvement, restricted diffusion and restricted diffusion. Here it is when you find calcification, it is osteosarcoma, fibrous dysplasia, expansion, fibrous dysplasia. There is fibrous dysplasia, expansion of the bone with no erosion or periosteal. Chondrosarcoma, we'll find there is rings and arcs. And here it's osteochondroma, exostosis, fibrous dysplasia, osteochondroma, Ewing sarcoma, osteosarcoma, and chondrosarcoma. This is perineal tubercle. This normal. This just can be the reason of impingement on perineal tendons. Can be a reason for tear. This calcaneal pseudocyst, which is not a tumor, and don't forget this could be associated with this Giessen angle of Giessen. Please, for this angle of Giessen, cyst at the angle of Giessen, okay, is not something serious or tumor. These intraosseous lipoma, you can find here this high signal and the interosseous calcifications. Unicameral bone cyst of the calcaneal bone. Chondroblastoma with the equivalent, with the posterior third of the calcaneum, the equivalent is considered as epiphyseal equivalent. Aneurysmal bone cyst with the fluid level. And here is the erosion, also here epiphyseal equivalent giant cell tumor. Don't forget closure of the epiphysis. This small osteoid osteoma, and here is osteosarcoma when you find destructive lesion with calcifications, soft tissue compared to bone involvement. So, and some sclerosis here, you will find this Ewing sarcoma, chondrosarcoma with chondroid matrix, and search for the ring and arcs, which is not so obvious. So it is not typical for me, but I have to consider it in my differential because the chondroid matrix. Okay. Don't touch lesion, cortical desmoid in children. It is not a tumor. Here it is the geoid cyst, non-ossifying fibroma. Osteopoikilosis does not doesn't it involve the epiphysis, which differentiates from the METs, which the sclerotic METs, which more commonly spare the epiphysis. There is old infarct, early infarction when there is lucency, old infarction when it becomes sclerotic. And here it is, I think this the lucency here. I think this is the lucency. Yeah, lucency here. This synovial herniation bit, it comes in the FRCR2 exam, and this is not tumor. This lucency here is not tumor. This is nothing. Don't call it anything. Don't ask for MRI. These don't ask for MRI for this. This pseudo lesion, all these are pseudo lesions, and this avian spur. Okay, it is not a tumor. And here it is the cyst. This is the collection. This herniation bit cyst. Okay, this is not a fracture, just because this is related to the. I'm sorry. Okay, I will say it, but just I will finish now. Just okay. This is not a fracture. Just this is synchondrosis. Okay. This is not a fracture. This is as mentioned, that trabeculation, the area of trabeculation. how to manage a tumor case, age, symptoms, X-ray, orthogonal views, avoid, don't touch lesion and variants, Bedfall, MRI and CT for characterization. Remember, the most important role of radiology is the degree of the aggressiveness. These are the reference of my lecture. I hope you are happy with this lecture. I know that this is long lecture, but try to listen and read the presentation. I think I spent 3 weeks stuck to my chair to do this, to make this presentation. All the best. And for the inostosis, the signal, the inostosis brush borders, the density is more than 1060 Hounsfield unit compared to which is higher. It should be higher than 1060. Lower than that, there is a concern about sclerotic nets. Please send me back your feedback. Okay, this is very important for me. This is very important. Okay, because I read every single word you mention in the feedback and try to improve and do and the improvement, I think also you get benefits from that. Okay, thank you everybody. Any questions?